Welcome to the Perspectives in AI seminar of the C4AI. This is a seminar that the Center, which is a cooperation of IBM, USP, and FAPESP, stages almost every month and brings some of the best and most representative researchers in AI of the world to present what they're doing and to discuss where AI is going, what are the limitations, and what we can expect for the future. If you want to learn more about the center, please check our website, which is going to be posted here. And before any more delay, I would like to introduce you the speaker of today. The speaker today is Nuria Oliver from the ELLIS Alicante Foundation Data Pop Alliance. I know Nuria since our PhD at the MIT Media Lab. It's great to see her again. Nuria has been a researcher in the areas of machine learning, AI for 25 years, or at least. And she's now a fellow of ICM, IEEE, and EurAI. She's the author of many works, a lot of interesting research, and I think I'll leave to her to talk a little more about herself, about what all she has done, and to present this very interesting work has done recently related to data science applied to the issues of the COVID-19 pandemic. Nuria, thank you so much for coming. I know it's a little late in the day in Spain, where you are. Thank you for joining us. It's early here. It's about noon here in Brazil, a little earlier in the US. We have people from many different places in this webcast. So thank you again. Please go ahead.
Thank you, Claudio. It's really great to be here, and it's great to see you again after all this time. And thank you for the invitation to share with all of you a little bit of the work that we have been doing since March of 2020 on the use of data and AI to help make better decisions in the context of the COVID-19 pandemic. And this is what I will be talking about today. So the main purpose for the work that we have been doing is to assist in better decision making and better policy making during the pandemic through the analysis of data. And to do that, we gathered a team of experts from the Valencian region in Spain. The Valencian region in Spain is located on the east of Spain, on the Mediterranean coast. You can see here on the slide. And since March of 2020, a group of researchers from different universities and research centers in the Valencian region, you can see their names here, have been working with me on using data to help the president of the region make better decisions. So what is it that we have been doing, and why? So the main purpose for our work is to fill the gap that there is between where the data is and where the decision makers and the policy makers are. If we see data as a digital representation of an underlying reality, and if we would like the decisions and the policies to be informed by reality, to be evidence driven, then we should be able to leverage that data to inform the policy making. And that has been the purpose of our team, because traditionally there is a gap between where the data sources are and where the policymakers are, because it is not trivial to actually make sense, of all that data, particularly given that this is non-structured noisy data like mobile data or health data, or data coming from non-standard data sources. So we have particularly been working on 4 areas. The first one is human mobility analysis, because of course an infectious disease that is transmitted from person to person, like coronavirus, it doesn't become a pandemic if people don't move. So understanding human mobility and modeling human mobility is very important. And in fact, the most common tool to try to contain a pandemic is to constrain mobility, because then you can geographically, sort of like stop the progression of the disease. The second area that we have been working on is building computational epidemiological models. So these are models on the computer that enable us to predict the number of COVID-19 infections, not only under the current situation, but also under different possible scenarios of different interventions. For example, what will happen if we close schools? What will happen if we close the borders? What will happen if we shut down, the restaurants, and so forth. The third area has focused on building predictive models, and we have built 3 main types of models: models to infer the prevalence of the disease, models to predict the hospital occupancy, and models to predict the intensive care occupancy, because this pandemic has really put a lot of strain on the healthcare systems in most countries in the world, and having accurate predictions of the load on the healthcare system is very important for policymaking. And then last but not least, we have been running since March of 2020 a very large citizen survey. It's an online survey where we've been getting feedback from people on their situation and their perception of the pandemic throughout all this year and a half. Still, the output of all these modules is pretty technical. And as you can see, there is still a gap, between where the output of these modules are and where the policymakers are. And I think one of the key elements for the success of our team is the fact that we have this layer here in this sort of beige color of interpreting the results and aggregating and preparing the results so they're actually understandable by non-experts. And a key member of our team is the Director General for Public Policies, working for the President of the Valencian Government. So she's has been a member of the team since the very first day. She's been coming to every single meeting, and she's been very helpful in understanding, in helping us determine the priorities of our work, but also in translating our work into political language so it can actually be used by them. In terms of the technical skills, so everyone has a background on sort of data science, but it's depending on the area of focus, there might be different areas of specialization. For example, the mobile data analysis team has a lot of experience in spatiotemporal data analysis and data wrangling. We're talking about huge amounts of data. The epidemiological team has a lot of expertise on computer models and sort of mathematical models. The predictive modeling team has a lot of background in machine learning, and the citizen science team has also a lot of background in statistics and sort of human-computer interaction. We have been working together since March of 2020, even though we never met in person. We met every day for many, many months. I schedule a meeting every day. This is an example of one of our meetings, and we have had a very intense way of working. Every day I wrote a report by 5 p.m. with all the predictions and also recommendations, observations, relevant information. We share our code using a GitHub repository. Of course, everyone has signed the necessary code of ethics, and NDAs, and we have a Slack channel that we use all the time. Since the summer of 2020, so since the fall of 2020, we've been meeting weekly, but for example, if in the period between December of 2020 And March of 2021, we also met daily. So it depends a lot also on the situation, on the pandemic situation. We have a website that you can go to in the Valencian Government website, but it's in English, it's in Spanish or in Valencian, it's not in English. And the team has actually received a certain amount of international visibility. And I think it's because it's not easy to create and sustain such a team. There are many challenges that make it difficult to have a team like our team. And we actually reflect on a lot of these challenges on this paper that we wrote in April of 2020 for Science Advances. Some of the challenges involve the lack of capacity and digital mindset in a lot of governments and public administrations. There are a lot of difficulties in terms of accessing the data. I talked about the data being a digital representation of an underlying reality, but the reality is that a lot of the public administrations are really not digital, and they don't have a systematic way of capturing data. There are, of course, concerns about privacy and data protection, but I want to highlight that all the work that we have done has been done using anonymized aggregated data that has no personal implications in terms of like privacy. There is a gap between where research ends and where the real world starts, so to say. And bridging that gap is always a challenge. And then, of course, in the case of a pandemic, when you have to make decisions every day, many times a day, if we don't have all these other elements in place, it's very difficult to operationalize and to be able to include the results of analyzing the data in all those decisions. And that's why our group has also been featured in some international media, like in Politico or on MSNBC, or even yesterday, Wired wrote this really long article about our story that I recommend you to read if you want to know more about our story. So what have we done? So I'm going to quickly share with you in the next half an hour or so some of the results of our work in each of these areas, starting with the mobile data analysis. So we were appointed by the Vice President of Spain, Vice President Calviño, the pilot region in Spain, to be able to access human mobility data derived from the mobile network infrastructure in a collaboration that the National Office of Statistics of Spain had with the three largest telcos in Spain, which are Telefónica, Vodafone, and Orange. So from that data, we wanted to be able to answer some really important questions. For example, are the confinement measures working? Has mobility changed? What kind of mobility has been the most impacted? Have all the regions changed mobility equally? And then, of course, is that enough? Or should we constrain mobility even more to contain the spread of the virus? This is an example of the visualization of the mobility data that we have been analyzing. And this is the coast of Spain, the eastern coast of Spain. These are the Balearic Islands, and this is the Mediterranean Sea. So you get an idea. And Barcelona would be up here, further north. So some of the results of our analysis are, for example, analyzing the impact on the radius of gyration, which is the radius of a circumference that contains the majority of movements of a population. And we found that in the first confinement in the spring of 2020, there was a very significant reduction in the radius of gyration. In fact, 65% of reduction, which was higher than the average for Spain. And this means that if before the confinement, the population on average was traveling 10 kilometers a day, because of the confinement, that figure went down to 3.5 kilometers a day. So it's a very significant reduction. We also analyzed the impact of what we call the stay-at-home campaign. So in Spain, there was a campaign to encourage everyone to stay in their homes. Analyzing this data, of course, we don't know the exact address of anyone, but we have the concept of an area of residence. So this map here shows the smallest granularity of the mobile data that we analyzed. And as you see, the cells have different sizes because the size of the cell is depends on the population to preserve privacy. So these shapes, these irregularly shaped areas are defined as follows. For municipalities that have less than 5,000 people, they are all brought together into one area. And that's why, for example, this one is really big. So it contains multiple municipalities, but to preserve privacy, they're all together. Municipalities between 5,000 and 70,000 people, they are one area. And then municipalities that are really larger than 70,000 people, like Valencia or Alicante, then they're split into different areas that fulfill the conditions before. For each of these areas, we could infer how many people didn't leave their area of residence, so the area where they slept at night. They didn't leave that area for more than 2 hours during the day. So the idea was to measure people that didn't commute, that didn't go work, somewhere else. And we found that on average during working days, 88% of the people did not leave their area of residence. And then during weekends, 92% of the people. And that's why the map is all very green, because the greener the map, the larger the percentage of the population that stayed at home, that didn't leave their area of residence. And that was during the first period of confinement in Spain, which took place from mid-March until the end of April. This is a visualization of that value, the percentage of population that stayed at home over time. And the greener the map, the larger the percentage of people that stayed at home. You can see that at the beginning of the pandemic, there is a fair amount of the map that is yellow still. But then during the confinement, especially the period between March 30th and April 14th, there was no labor mobility. And we can see how the map becomes pretty green, meaning most people stayed in their area of residence. We performed all the mobility analysis under different spatial granularities. The finest granularity are these areas that I just showed, but from a public health perspective, a very useful spatial granularity scale are the departments of health. In the Valencian region, there are 24 departments of health, and the Department of Health is the region, the geographic area that is served by one hospital. So there are 24 hospitals, and each of them serves a certain area. So we performed all the mobility analysis also at the Department of Health level, and we can see here the percentage of the population per Department of Health that didn't leave their area of residence during weekends, which is in the brown color, and during working days, which is this reddish color. So you can see all of them were above 80%, and there were some variations depending on the Department of Health. We also analyzed the impact of labor mobility. So we compared the percentage of people that left their area of residence during working hours with a day before the pandemic, which was in November of 2019. And here we show the difference in labor mobility. So the greener the map, the larger the difference when compared to a reference day in November. And we can see on average 60%. So we observed 60% fewer people outside of their area of residence during working hours than a reference day in November. Because we have incoming flows and outgoing flows to each of these areas of residence, we computed an indicator called the activity levels. And we also measure how the activity levels change because of the confinement. Here we are measuring the difference in activity levels when compared to a day in November of 2019, before the pandemic. And we see that at the beginning of the pandemic, this is March of 2020, the map is not really totally green, and we can see, there are some areas like here that are orange, which means the drop in activity levels wasn't very high. Maybe it was less than 15% or less than 20%. However, when we look at the activity levels when there was no labor mobility, except for essential professions, we have observed a very significant drop in activity levels, and where all the regions had a drop that was higher than 60%. The same drop in activity levels obviously is observed for each of the departments of health. These are the geographic regions that are served by each of the hospitals in the Valencian region of Spain, the 24 departments of health. To be able to communicate all these results and to enable anyone, including obviously policymakers, to make use of them, we built a website that is publicly available, and you can click on any municipality and you can see the changes in mobility, the changes in activity levels, the percentage of people that stayed in their area of residence, and so forth. Because we have incoming and outgoing flows, then we can run community detection algorithms and identify what we call mobility communities. And a mobility community would be a geographic area that is very self-contained in terms of mobility. It has a lot of inner mobility, but it doesn't have a lot of mobility with other areas. Applying this community detection algorithm, we identified 14 communities of mobility. And this information is valuable because if the government is considering applying partial confinements, it's very important to understand how a partial confinement would actually impact mobility, how self-contained the region that you are confining is or not. The second area of work has been building computational epidemiological models. And basically with these models, what we want is to be able to answer the following questions. How many infected individuals will there be under different scenarios? And of course, are the contention measures enough, or should we do more? We have built 3 different types of models. The first one, which is the most traditional one, is a SAIR metapopulation compartmental model. So these kinds of epidemiological models divide the population into metapopulations or compartments. And the SAIR one divides the population into 4 different compartments or states, which are the 4 letters of the acronym. So the model assumes that everyone in the population is in one of these 4 states. Initially, because SARS-CoV-2 or coronavirus is a new disease, we assume that everyone is susceptible to the disease. Then with a certain probability, beta, a percentage of the population is exposed to the disease. Then with a certain probability, those that are exposed become infectious and infected with the disease. And then with a certain probability, they recover or they die, so they get retired, sort of like from the system. And then, of course, after a certain number of months, if the immunity wears off, then they might be susceptible again. So this kind of model is given by these differential equations, and depending on the disease, you have to estimate the different parameters that determine the different probabilities to transition from one state to another state. So for COVID-19, those parameters have been estimated, and we fine-tuned the model for the Valencian region, and we also included the mobility information that we had from the mobility analysis. So using this model, we have been building daily predictions on the number of cases in each of the provinces in the region, and also in the overall region. The second type of model that we have built is an agent-based epidemiological model, and we have built one using a framework called REINA. So with this model, instead of modeling the population as a meta population, clustering people into different groups, or states, in this one, you model each person individually using agents. So we have 5 million agents because there is 5 million people that live in the Valencian region. And each of them can also be into one of 4 states. So there is an underlying SAIR model underneath this agent-based system. But the difference is you model the interactions between the different agents. The agents have age and have gender, and they have a contact matrix that determines with how many other people they usually have contacts. And then you basically run simulations with all these agents, and then you inject some infected individuals, and then you sort of like get the evolution of the disease. And we've also been building daily predictions using that model. In addition, in November of 2020, I received an email advertising an XPRIZE competition called the XPRIZE Pandemic Response Challenge, which was sponsored by Cognizant. And it seemed like an interesting competition, very ambitious. The goal was to use AI to predict the number of COVID-19 cases in 236 regions and countries in the world, taking into account the different interventions applied in each of these regions and countries. And then the final stage in the challenge, the goal was to build a prescriptor of interventions. So a recommendation system that would recommend policies to be able to have the best trade-off between the number of cases and the cost of the interventions. Because of course we know that applying all these interventions is very costly in economic terms and in social terms. So I share with the team this email that I got announcing this XPRIZE competition, and a couple of people in the team were very enthusiastic and they really wanted to participate. I thought it was a huge challenge, but especially because the challenge, also this competition, was starting, I think it was December 1st, and it was ending in February. So it was all Christmas, working really, really hard, on this competition. So I told the team, okay, this is really hard work, even harder than all the hard work that we've been doing so far. But, they were really into it. They really wanted to do it. So we put together a team, which is a subset of the larger team that we had been working together since March of 2020. And we called ourselves Valencia IA for COVID-19. So the first challenge was to build this predictor of COVID-19 infections. And we decided to do something completely different to what we had been doing so far. And we built deep neural network-based predictor using LSTMs, specifically 2 different channels of LSTMs, a bottom channel to model the interventions applied in each country or region, what we call the actions. And you can see here with the A. And then a top channel that is actually a bank of LSTMs. And this bank of LSTMs models the number of infections in each of the countries and regions in the world. And then they are combined in this lambda layer that sort of like modulates the number of cases depending on which actions are implemented in each country or region in the world. We built this bank of LSTMs to be able to capture the diversity or in the dynamics in the number of cases in the entire planet. So we first clustered all the world, all the countries and regions into different clusters, depending on their dynamics of their infections. And then we trained different LSTMs for each of the clusters. And we had, I think, 9 clusters to model all the countries and regions in the world. So during the XPRIZE competition, there was an evaluation of all the teams that were participating. And our team was, our model was actually doing pretty well. I think we were 3rd in mean rank globally and 1st in all the European countries and the Asian countries in mean rank. So that gave us a lot of energy to continue. And we're like, wow, this is not bad because we had been working mainly with data from Spain or from the Valencian region in Spain. And this was like another level because I had to be working with data from the entire planet. But more importantly, we could use this model during the 3rd wave of infections in the Valencian region, which was the worst wave. It was right after Christmas. Everyone got together for Christmas and we had this huge wave of infections. And you can see here the ground truth in yellow, so the real number of cases, and then in blue what our model predicted, and in red what baseline model also using neural networks predicted. And you can see that our model was actually quite accurate in predicting the peak of the infection and the day of the peak. And that was actually very helpful for the government to really determine, if when, we're going to be reaching the peak and if we needed to apply more interventions or not. The final phase of the XPRIZE competition was about building this prescriptor or this recommendation system of intervention policies. And it was basically kind of building an artificial politician. The idea was to identify the set of policies that would be on what is called the Pareto front in a two-dimensional space, where one dimension would be the cost of those interventions. And in the other dimension, what we have is the number of cases that you would get if you were to apply those interventions. And this Pareto front has two extreme policies. One, which would be I do nothing, and the other one, which would be I apply all the interventions possible. So the policy I do nothing, the cost is the lowest because you are not applying anything, so you are not it's not really costing you anything, but the number of cases is the highest because you are doing nothing. In the policy of I apply every possible intervention, the cost is huge, but the number of cases is the lowest because you are shutting down the entire country. And between those two extremes, there were 7.8 million different combinations of interventions that every day you could apply. And the challenge was to identify a set of 10 optimal policies that would be on the Pareto front, which means that they will have the best trade-off between the cost of those policies and the number of cases. That is, for the same cost, there would be no other policies that would give you that number of cases. All of them will give you more cases, or for the same number of cases, of COVID-19 cases, your policies are the cheapest. Any other policies that would give you that number of COVID-19 cases would cost more money. So we had to do that for the entire 236 countries and regions in the world, and in less than 6 hours. And our system was actually able to do it in like 2 hours, so that was quite efficient. And we built a visualization of our recommendation system of policies, so the actual policymakers could use it. And then you could select the country, and each of these dots is one policy. And this is the Pareto front. So on one axis, we have the cost, which is called stringency. That's the cost of the policies. And on the other axis, we have the number of cases. And the policies themselves combine 12 different types of interventions. So you can have school closing interventions, workplace closing interventions, canceling public events, restrictions on gatherings, and so forth. And so the system could determine the activation levels of 12 different kinds of interventions. So we finished all of this in February, and then I guess there was the judging, of the competition. And to our surprise, we actually ended up winning this XPRIZE competition, and we were really, really happy. But also, we were very happy because it was a great motivating factor for us to develop a lot of new methods to help make better decisions. And that was the main reason why we wanted to participate in this challenge. The third area is building predictive models. We've been building predictive models for the cumulative incidence, for the hospitalizations, for the intensive care units occupancy and deaths for each of the departments of health. And we've built these predictive models using more classical statistics methods, but also using deep neural networks, particularly also LSTMs. And this is an example of our LSTM predictor of intensive care occupancy. And last but not least, we've deployed a very large-scale citizen survey called the COVID-19 Impact Survey, because we realized that there were a lot of very important questions about people's experience during the pandemic that we didn't have any data source for, and that we couldn't answer because we didn't have any data. So in March of 2020, we decided to launch an anonymous online survey to try to answer these types of questions. What kind of social contact behavior people have? What is the economic and labor impact of the pandemic? What's the resilience of the population, when facing all these restrictions? What is the prevalence of symptoms? Are there tests, or there are no tests? What's the emotional impact of the pandemic? What kind of individual protection measures do people take? Is contact tracing working, or it's not working? These are some of the questions. So we spent a fair amount of time in March of 2020 designing the survey, and we collaborated with different experts, and we converged into 26 questions. So it was the shortest survey possible that would give us the maximum amount of information. We translated it to many different languages. Here is the survey. And we actually have a lot of data from Brazil. So I will share some of the data from Brazil. And I encourage you to participate in the survey and also to share with your friends and your colleagues. Ideally, you answer the survey every week because, of course, your situation and also the pandemic situation changes. So it's a survey that ideally you respond regularly. We got a huge amount of response to the survey when we launched it. In the first 40 hours since we launched it, we got 140,000 answers. And the servers couldn't keep up with so many answers. And we felt so grateful to so many people who answered the survey that we very quickly wrote a paper where we shared the data, the first week of data collection, and we shared the main results. So everyone could learn from what we had learned, by doing this survey. We also built 2 visualization tools. The most up-to-date is the one on the right-hand side using Tableau. And there we have all the data until September, until now, until a couple of days ago. And you can select the country. And we have data for Brazil as well, Spain, Germany, and Italy. Those are the countries that we have the most data for. When the first peak of infections happened in the spring of 2020, there was a very important question that we needed to answer. And the question was, have we reached herd immunity? At the time, there were no tests. And no one really knew how many people had actually been infected with coronavirus. As you might remember, Spain was one of the most impacted countries in the world. And of course, the question was like, maybe we got already so many people infected, that we have herd immunity, which was like the dream, at the time. So there wouldn't be any more waves. So we did a study to try to answer that question. And we did the study using 3 different methods. The first one was using our survey. So we built a generalized linear model that was taking as variables the presence of a person in the home infected with COVID-19. That's one question in the survey. And then the symptoms, which is another question in the survey. And then the gender and the age. And using that model, we infer the prevalence of the disease in all of Spain. And then later on, like 2 months later or a month and a half later, there was a seroprevalence study that was carried out by the Department of Health, and then we could compare the results. And we actually found out that our estimations were actually very accurate when compared to the seroprevalence study. And according to our estimations, in the Valencian region of Spain, the prevalence was between 1.6 and 3.4. So very far away from 70% for a herd immunity. The second method was by analyzing the death data, both the deaths and the excess of deaths. And then from there, inferring how many people you would need to be infected to explain the number of deaths, that were observed. And following that approach, we got an estimation between 1.5% and 4% of prevalence, so very low too. And then the last method was using our SAIR epidemiological model, because our model has an underlying number of infected individuals, which is the red line here. And as you can see, is much, much larger than the blue line, which is the number of reported infections. So using the number of infected individuals, according to our SAIR model, we had 2.3% of the population. So the answer was, no, we are very far from herd immunity. So there will be another wave. So our most important message was there will be more waves as soon as we start relaxing the measures. We also carried out a lot of simulations to understand the impact of contact tracing, to see if you really needed 100% of contact tracing or not. And according to our models, even with only 40% of contact tracing, you could really flatten the peak of a second wave. But assuming that everyone that was positive could self-isolate, something that we know that is not true. So that is a very optimistic scenario on the impact of contact tracing. And then since May of this year, we have been working on adding vaccination to our agents-based model and to our deep learning-based model. And now we have models that take into account the vaccination. And then just to wrap up, the last part that I wanted to share with you of results is some comparison of some of the answers to the survey between Spain and Brazil, just to see some of the differences in the two countries. You can look at all these results yourselves using these visualizations on this URL, but I thought I would just share with you some of them. So the first one is the emotional impact of COVID-19, depending on age and gender. So one very important message that we have been sending here in Spain since April of 2020 is that it is young people and it is women, the ones that are the most emotionally impacted by the pandemic. Here in reddish color, you see women, and in bluish color, you see men. And these are the age ranges. And as you can see, the levels of stress and the levels of anxiety are very significantly larger among the youth, and they are larger among females than males. So that's a very important message. But even loneliness is also much larger among the youth than any other age group. So providing support to the youth, emotional support, psychological support, is a very important measure to take. When we look at the data from Brazil, we have very similar results. Anxiety is actually huge, according to this data, among young female Brazilians. But we can see that the youth is, again, the group that is reporting the highest levels of stress and anxiety, and loneliness when compared to other age groups. Another question in the survey is about the perception of the government measures. We asked people, do you think your government is doing enough, which is the green line, should do more, which is the yellow line, is doing too much, which is the red line, I don't know, which is the purple line, and I prefer not to answer, which is the blue line. And this is the evolution throughout the entire pandemic. And as you can see, it matches pretty well the waves. So whenever there is a wave, everyone thinks they should do more. And then when the wave goes down, then they relax. And then there's another wave, they think they should do more. But in Spain, this is Spain, basically, since the summer of 2020, the most popular answer is that they should do more, fundamentally. And only now things are starting to going down, and the people that think that they're doing enough, is going up. And this is the data for Brazil. So for the entire pandemic, it seems that the most popular answer by everyone almost is like that they should do more. We also have information about the individual protection measures that people adopt. So if they disinfect hands, if they wear a face mask, etc., including if they're willing to get vaccinated or not. And here there are some interesting gender differences, and also is very remarkable the very high willingness to get vaccinated in Spain, where, on average, is roughly 91% of the people say that they want to get vaccinated. So the very consistent result, this is only the last 2 months, so the data is the same for the entire pandemic. Women are a lot more compliant with the measures than men. Women are the reddish bars and men are the blue bars. And you see that the differences are very significant in some of the protection measures, except for one protection measure, which is installing the contact tracing app, where more men than women report having the app installed. The rest of them, women are a lot more compliant than men. In Brazil, the results are very similar. Women are a lot more compliant than men. Again, men have the app installed, in this case, twice as likely than women. The percentages are very low. compared to Spain. In Spain, we have a much larger percentage of people reporting that they have the app installed compared to Brazil. And the intention to get vaccinated is extremely high in Brazil. We also have the evolution of the perception of risk of different activities over time. So this is since May of 2020 until now, different activities like flying by airplane or doing individual sports or going to schools. You know, the question is, do you think you can do this activity with low risk of getting COVID-19? And as you can see, the activity that is always considered the safest is doing individual sports, which makes sense because if you're doing sports by yourself individually outdoors, I don't know how you're going to get COVID-19. And the activity that is always considered the least safe is flying by plane, even though there isn't really any a lot of reported outbreaks in planes, but this is the perception. Some activities are very seasonal. For example, going to the beach, which is the red line, it reached the lowest values in November, in the winter. And then as soon as the weather was nice in the spring, everyone thought it was safe to go to the beach. So I think there is a high correlation between people doing these activities and then thinking, you know, that they are safe. And then another interesting one has been schools, which is in pink, where the perception of safety started really low. You can see here, it was around less than 10% of the people thought that going to schools was safe in May of 2020, or April actually of 2020. And then it went up a lot, and it has actually stayed, you know, up. It still is less than 40%, but you know, it multiplied almost by 3. When we look at Brazil, the ranking is similar. So the safest one is also doing sports individually, and the least safe one is flying by plane. But the perception of safety in general is much lower. The largest value here is 70%. In Spain, it will be around 80%, and all the values are much lower. So I think in general, the perception of risk is larger in Brazil than in Spain. We have another question to understand the type of environment where people socialize. So we classify the type of environment in no risk, which means I don't socialize with anyone. In low risk, which means I socialize using protection measures and also outdoors. Medium risk, which is I socialize using protection measures. So I wear a mask, I ensure there's ventilation, I keep the distance, but it's indoors. And then high risk, which would be I don't take any measures and I socialize indoors without any measures. You can see that there is a high correlation between the high risk socialization and the number of cases, which is these black lines. And in general, in Spain, in the summer, these are different regions of Spain, the different columns. So adding up the no risk and the low risk is the majority of people. And in Brazil, it's actually similar. It's quite remarkable that a very large percentage of people say that they don't socialize with anyone, especially in Sao Paulo. I don't know to which degree this is true or not, but according to the data, there's a very large percentage of people that report not socializing with anyone from outside the household. A very important pillar in the control strategies of COVID-19 is the ability to self-isolate. In fact, the control strategy is called TTI, which means trace, to know whom to test, to know whom to isolate. Because the idea is if every positive case isolates, then they don't infect anyone, and then there is no community transmission, and then there is no wave of infections. So self-isolation is absolutely necessary. So we have one question where we ask people if they would be able to self-isolate if they were detected that they had COVID-19. And there are several important messages here. The first one is that if we look at the people that are the most vulnerable, the people that are 60 plus, a very large percentage of them say that they could self-isolate. The brown bars here are the people that have no barriers to self-isolate. So 72% of the people say that they could self-isolate. So that's good news. However, when you look at the younger people, this percentage goes down a lot, and roughly half of the people say that they cannot self-isolate. The main reason is because of sharing the home. But there are gender and age differences. First of all, we have a very significant age difference in the psychological reasons where people aged 18 to 29, a much more significant percentage than any other age group reports that they are unable to self-isolate because of psychological reasons, because it's psychologically impossible or because they are scared of a stigmatization. And the other important difference is a gender difference in those that say that they could not self-isolate because they have to take care of children, where you can see in Spain, in the age bracket 30 to 59, 28% of women, but only 12% of men say that they couldn't do it because of caring for children. So it's very evident that the burden of caring for children in Spanish society is in the women. When we look at the Brazil data, we have a similar situation. The most vulnerable population is the group that reports with a larger percentage that they don't have any problems self-isolating. So this is good. The younger groups, a very large percentage, they report that they could not self-isolate because of sharing the home mainly. And we observe the same age and gender differences. So it is the youth in Brazil as well that they report that it's psychologically impossible to self-isolate. And look at this, the women in Brazil, but there is an interesting point here, because also the women age 18 to 29, something that didn't happen in Spain but seems to happen in Brazil, women age 18 to 29 and women age 30 to 59, they are significantly more likely to say that they cannot self-isolate because of having to take care of children when compared to men of the same age group. So again, in Brazil as well, the youth is the group that is the most psychologically impacted, and the women carry the burden of childcare during the pandemic. And finally, I wanted to share with you some data that we have from the survey on how effective the contact tracing app is or has been. And this is data since August of 2020. So for that sample, we have 130,000 answers, of which 31% report having the app installed. So that's really high adoption in the Spanish sample. Out of these 40,000 people that say that they have the app installed, 7.9% they say that they had a close contact with a positive case. So they are susceptible of receiving a notification from the app because they had a contact with a positive case. At least 1/3 of these people that they had contact with should have the app installed. However, only 86%, or it's only 86 of these people actually discovered that they had a close contact with the app. More worrisome is that only 27 of those got tested. So you actually get a lot of people that don't get tested, of which only 7 tested positive. So from our original pool of 130,000 people, the app helped identify 7 positive cases. For the Brazil data is somewhat similar. It's a smaller sample, it's 38,000 people. The adoption rate is much lower of the app. Only 5% of those say that they have the app installed. But then when we look at the number of cases, out of a pool of 38,000 people, the app helped find 2 positive cases. So very small impact of the app. So what have I learned after all these months of working on this topic? So I think the main lesson is a very obvious lesson that everyone probably knows by now, which is a pandemic is not just a public health challenge. It is a societal challenge. And that's why addressing and tackling this pandemic requires a holistic approach. And from my perspective, we have a huge opportunity to create a virtuous cycle between these 3 elements that I think we haven't really properly, achieve during the pandemic, the COVID-19 pandemic. The first pillar or the first element is data. Data is absolutely critical, but by high quality data that is systematically captured and analyzed and shared, data that enables us to understand where we are, but also why we are where we are, and enables us to predict where we are going, and enables us to actually make informed decisions about where we are going. We also need to invest in the necessary human resources and technology So really hire the right number, of healthcare and social workers and contact tracers and teachers and researchers, but also they should be empowered with the right technology. It doesn't make any sense to have a lot of contact tracers if they are using technology from the 90s, because it probably doesn't scale, to the needs of the pandemic. And then all this data and all this work, and all these people working should actually be key to inform the public policy making, and it should be key to allow us to identify weaknesses in the system and then deploy policies and deploy processes that tackle those weaknesses. For example, if we know that it is the youth, the demographic group, that is carrying the psychological burden of the pandemic, we should probably deploy programs to support the mental health, of the youth. If we know that women are having the burden of childcare, we should definitely invest in childcare programs. If we know that 50% of the people younger than 60 years old is unable to self-isolate, we should probably provide infrastructure, for quarantine, so people actually can self-isolate, and so forth. So we reflect on these issues and the intersection between data, technology, and COVID-19 in this publicly available report or paper that I co-wrote with Data Pop Alliance and the Vodafone Institute. So if you want to know more about this, I encourage you to read this paper. And then more broadly speaking, throughout the pandemic, we have actually written a lot of papers, and actually next week, we are presenting the technical details of the XPRIZE work that we did in ECML, PKDD, and we actually have won Best Paper Award in the Applied Data Science track. So we are very happy about that. And if you are interested, I encourage you to look at the presentation that we will do next week. And here there are a lot of other papers also on the results from the citizen survey. So thank you very much for your interest, and I encourage you to take a look at the survey and, of course, to answer it if you would like to help out. Thank you.
Thank you, Nuria. It was absolutely fascinating, absolutely great. First of all, I want to congratulate you and your team.
Thank you.
For sort of stop doing whatever else and get involved. Let's help all these people and the government and the authorities to, and the people itself, the people that you talk directly about what's going on. I have to say, it's so refreshing to see so much data and science in this arena that I think here in Brazil we have been really started with anything like that. Yes.
Thank you. No, I was just saying that, yeah, I mean, we dropped everything. That's true. We've been thinking about COVID-19 and breathing COVID-19 and sleeping, COVID-19 for a long time. Yeah, I mean, I think one of the most fulfilling elements of this experience for me, because I had never worked with any of these scientists. I didn't know them. We never met in person. We only met in person a couple of months ago. We had never seen each other in person, but we saw each other every day, for many, many months. Is how powerful it is when you have a group of people that are motivated by the same mission. Like we were all motivated by the mission of trying to help with our knowledge, and our expertise in the pandemic. And for me, it has been really inspirational to see how you can sustain the levels of motivation and these levels of intense work, like really intense work, when there is a purpose and when people see the purpose, of what they are doing. And that has been really a very unique experience.
Okay, no, so I want to encourage people to post questions in our YouTube channel. We already have some. We have a good amount of time to talk more with Nuria. The first question I've been asking everyone who has been in the seminar, some of them from our MIT days, like Trevor and so on. But the question is, how do you think the pandemic affected research in AI? First, in general, it seems in your case it affects deeply, but what do you think will be different when we think about AI in the future because of the pandemic?
Well, I mean, I think in terms of AI, the impact of AI on helping fight the pandemic is sort of like it has multiple areas of impact. So the first one is using AI to accelerate the discovery of treatments and vaccines. So there's been tremendous progress on using AI methods for drug discovery, for protein folding, inference, for a lot of fundamental challenges in biology and in chemistry that AI is really accelerating a lot of the discoveries there, and I think that's a very important area. The second area is the use of AI algorithms, and when I say AI, it's mainly data-driven machine learning algorithms fundamentally. The use of AI algorithms for clinical decision-making support. So predicting, or diagnosing COVID-19 from X-rays or from other radiological, images, predicting the probability that a person will need a ventilator based on their symptoms and their health records and their age, and their gender, or predicting how effective a treatment will be, also based on the symptoms, and the age and the electronic health records. This is something that that is being done and will continue to be done. And then the last area is what I just described: the use of data-driven AI algorithms for public policy making and for supporting public policy making. This is sort of like the immediate impact. And then we have the sort of like collateral impact, because of the pandemic, we have had to significantly change our lives. We had to spend most of our days indoors, probably in our homes, and we had been limited to using technology to talk to each other, to work, to learn, to be entertained, and all those applications of technology, they use AI. I mean, if you can have a virtual background in your meetings, it's thanks to AI. If you can have simultaneous translation in meetings, it's thanks to AI. If you can have recommendations of movies, for entertainment, it's thanks to AI. So I think the exposure of AI in our daily lives has increased a lot, mainly because our technology use, has increased a lot. But then we have the impact not only on AI, but I think the impact of the pandemic on science and on scientific discovery. And there, I think the impact has not necessarily been universally positive. There is research that has shown that there has been a significant differential impact on the scientific productivity between female scientists and male scientists, where female scientists haven't been able to publish nearly as much as male scientists, mainly because of what I just talked about, because of childcare. So I worry about the consequences of that, because we know that diverse teams generate a lot more inclusive and innovative solutions. And if the teams haven't been as diverse as they could have, because a lot of the women haven't been able to participate, there could be a significant negative impact on the sort of like creativity and the significance of a lot of these papers. And then there is also the issue of, in general, the impact of the confinement on overall creativity. I think we are able to do incremental work pretty well if we are confined, because we know what we have to do and we basically just do the same thing that we were doing, but coming up with new ideas, coming up with new projects, figuring out the next, potentially big thing that, that you could be working on. I think that requires a lot of human interaction, a lot of brainstorming meetings, a lot of going back and forth, with people, a lot of serendipity in a, a conversation that spurs an idea. And all of that has basically disappeared, during the pandemic. Even conferences, I mean, conferences are a huge source of inspiration, but not necessarily listening to the talk. Many times it's just, talking to people, and they tell you what they're doing, and you tell them what you're doing, and then you come out with an idea. It might be in the coffee break, it might be in a conversation after the talk, right? All of this is disappeared. So I think in terms of the quality and the originality of the scientific production, my intuition and my concern is that it's probably the pandemic has had a negative impact on that, because we haven't had a lot of the fundamental human interactions that are needed to support and to sort of like nurture the creativity that is needed to come up with new sort of like cool ideas. Yeah.
It's interesting. I think you are the fourth researcher in the seminar who points out that creativity is one of the most likely victims of the pandemic in AI. So
Yeah,
yeah, absolutely, I agree,
I think
absolutely.
so. Yeah, I mean, even in our case, I mean, we have been very creative, but we've only worked about one topic, which was the pandemic. We haven't worked about any other topic. But I think in our case, it was sort of like a no-brainer. We were so motivated, and we are so motivated. It was just like, I don't know how to explain it. There was this bond in the team with this common mission. Okay, we need to do anything we can, to help. So you became creative, but with a very clear purpose. But I think in general terms, yeah, I do worry. I mean, I've been program chair for ECML PKDD this year, and it's difficult to find papers that are really original. A lot of the work is incremental. And I think that has happened in most organizations. A lot of the work has just been incremental, doing more of the same, like just cranking the machinery. But doing something new, like a new project that involves more than one or two people, I think is very hard in the pandemic.
Okay, so there we have a question from Roberto Hirata about the mobile data, in terms of how much data you had from before the pandemic, and I would add how hard is to get that data, how was to get that data.
So from before getting access to the data initially was very hard, but Spain was very lucky, because before the pandemic, for a couple of years, the National Office of Statistics had been negotiating with the three largest telcos to get access to their data, to be able to build more accurate, well, it was a pilot to see if it was indeed more accurate, to sort of like have a new way of computing commuting matrices. So the National Office of Statistics, one of the statistics indicators that they compute is the mobility matrices. So how many people are commuting, how many people are going from A to B every day. And this is very important information for urban planning, for traffic planning, for pollution inference, for determining, the public transport system. I mean, it's very important for many reasons. So traditionally, these commuting matrices are computed using questionnaires. So it's very costly, and it takes a lot of time. So they thought, okay, we have access to the mobile data, mobile network data. So this is not data from smartphones. This is data from the antennas, antennas in the mobile network. And we actually do all the math to extrapolate. We could actually compute commuting matrices automatically, just by analyzing that data without having to do surveys. So for a long time, they had been working on that project, and they had solved all the legal issues and all the GDPR issues in Europe and all the privacy issues. And they defined these areas that I described to make sure that they were preserving privacy. And of course, everything is anonymized, and so forth. So that had also been done for, I think it took them 2 years. And the pilot for computing the commuting matrices was actually starting, I think it was November and December of 2019. Perfect. So it was right before the pandemic. And in fact, I wrote an article in El País, which is the largest, very popular newspaper in Spain, explaining the project, because the project actually had very negative publicity for the Spanish Office of Statistics, because there was no understanding of what kind of data it was. And when people think of mobile data, the way they were saying is, oh, they are tracking you. You know, the Spanish National Office of Statistics is tracking people. And then I had to write an article which is called No, the Spanish Office of Statistics doesn't know where you are right now, explaining that it wasn't GPS, that it wasn't data captured by any smartphone, that it was just the data from the cell towers, you know, and trying to explain that it had nothing to do with tracking people, right? So when the pandemic took place, it started in March, they had all that already done. So what we were able to do was get access of that to that data set that the National Office of Statistics had. So what they did is they negotiated with the telcos to continue getting the data. The pilot was going to finish, but they continued the pilot throughout the pandemic. Then that data was actually made public in June of 2020. So the data is public. You can access the data, any of you. I can send you the link. I can actually show it to you guys right now on my browser. So that's publicly available data for anyone to use, but it was not publicly available during the first wave, and we were able to access it because Vice President Calvino appointed us to be sort of like the pilot region to be able to use it. So I'll show you the here. So this is the publicly available data set. I can type in the chat. And here you can see this is Spain. This is the Valencian region of Spain. And then you have the incoming flows, the outgoing flows. So we took this data as the raw data, and then we computed some of the indicators that I showed to you based on this data. And you can download the data here. Descarga datos is like download data, so you can download the data as well.
Sounds wow, so great that sometimes you do things in science without exactly, or for one reason, and they become very useful for another reason. That's one of the beauty.
Yeah, so we were very lucky. We were very lucky in Spain that there was this project going on, and I think that enabled Spain to be one of the few countries that could actually leverage that data very, very early on. You can see here you have the data from November of 2019. That was the pilot, when the pilot started. And then we have March, April, May, and June of 2020. So this is the baseline. This is the baseline data. Yeah, and then we had another data set from the Ministry of Transportation, which was complementary to this data set. And then we've also analyzed data sets from Facebook and Google. So we've used multiple data sets, but the results that I showed from the first confinement, which was the very harsh confinement that Spain had, I think it was one of the most harsh confinements in the world. We couldn't leave the house. The children couldn't leave the house for like, I don't know, several weeks. They couldn't even go downstairs. They couldn't leave the house, period, like or all, in the spring of 2020. We've used different data sets, but the results that I presented were using this specific data set from the National Office of Statistics.
So one more question about that, the mobile data is, probably you're aware, I mean, there is some recent work from Alex Pentland, your PhD advisor, that sort of basically, if I understood correctly, he argued in using data from another area that the adoption of lockdown, of the restriction of movement was much lower in people in the lowest socioeconomic strata. That there was that poor people had to leave home probably to work. Did you see that in your data? Did you
so there was additional work on this, analyzing, I think was the Facebook data or the Google data that was published quite early on the pandemic, I think in the spring of 2020, where they were showing the time gap between when the rich sort of like people could reduce their mobility and when the poor people could reduce their mobility, and indeed that was the case. We didn't look into so in our data, the granularity, as I mentioned, are those areas of residence. And we talked about it in the team, but it wasn't like, I think it's as scientifically could be an interesting result, but it wasn't a super actionable result in terms of like the policy making, because I think from a policy making perspective, they is something that they knew that um, they knew that the social programs that they had to deploy to support people that were more vulnerable economically. So it wasn't like a super high priority to do something like this. Plus we didn't have the special granularity to look into neighborhoods, for example. So it's not something that we looked into, but I know several pieces of work that have identified that. What we did look into was in this pandemic, there is the concept that this pandemic is a syndemic, meaning that it doesn't affect equally every sort of like person in society, but it has affected disproportionately the most vulnerable groups in society, be it immigrants or people in poor neighborhoods or women or disabled people and so forth. So we looked into whether indeed we found any evidence that there was a syndemic. And we did that by looking into the people that had tested positive and the people that had tested negative according to the survey. And then we looked at the economic impact and the labor impact of the positives versus the negatives. And we found that disproportionately, so there was a very significant difference between the people that had tested positive and saying that they lost their, like they couldn't pay for their mortgage, or they couldn't pay for their food, or they couldn't self-isolate compared to the people that had tested negative. So so we found some indication that there was a significant correlation between having been negatively impacted by the pandemic and somehow testing positive, when compared to people that, that reported they didn't have problems self-isolating, or they had not been affected by the pandemic, and then they somehow, they were more likely to test negative than the other ones. There was also some evidence from Madrid, which is the largest city in Spain, of indeed mobility from the poor neighborhoods to the rich neighborhoods, because the people in the poor neighborhoods were the ones that were going to be like the wait, I don't know, serving in restaurants or cleaning, houses, or cleaning offices, or taking care, of old people and so forth. And there was, some evidence of that as well. But the data that we had, we didn't have that. We didn't look into that.
Great. So I think probably this is going to be the last question that was asked by Fernando Osorio. One of the characteristics of this pandemic was the abundance of fake news. And I imagine also in Spain, here in Brazil, we had from all levels, including even coming from the government itself. But the question is, do you have cases of you or people using your data, the resources you created to counter those fake news, to argue against that? Do you? And if not, I mean, how effective do you think you have been in helping this debate with all the efforts you have done?
So I mean, obviously, I think fake news is a pandemic in itself, and I think it's relatively, sort of like a global phenomenon right now. Having said that, I don't think in Spain we have suffered the level of misinformation that and disinformation that there has been in other countries. And I think one of the reasons is because, luckily, I don't think the pandemic has been really politicized in Spain as opposed to other countries. And I think that is one of the reasons why there is such high intention to get vaccinated in Spain. We don't have a lot of a very large negationist movement like there are even in other countries in Europe. So I don't think it has been a huge challenge. Um, I don't think there has been um, questioning by any political group on the effectiveness of the vaccine or the importance of wear masks or the importance of taking measures. I think every leader was wearing masks, every leader was getting vaccinated, every leader was recognizing that the virus exists and that that is not some made up sort of like story. Obviously, I think a positive, it's a sad fact, but I think it had a positive impact, is the fact that Spain was one of the most affected countries in the world in the first wave. So as a society, we suffered a lot. We know almost every, I would say almost every person or every person knows someone that has had coronavirus, that was hospitalized with coronavirus, maybe that even died from coronavirus. So I think because the first wave was so horrible in Spain and it was so obvious that the disease existed and it was so obvious that people were dying and it was so obvious that people were getting sick, I think that really made it evident in the collective understanding of society that this was real and that this was a real dangerous disease. I think in countries or regions where there wasn't such a bad first wave, I think that creates a more likely environment to for fake news to prosper. Because if it's something that, if you don't know anyone who's had the disease, if you don't know anyone who's been hospitalized, if it's just something you see in some news but you really don't see it on the streets, I think people are much more likely to question and to say, well, I don't know anyone, it could be fake. But when you actually know people, when you actually see the people being sick, I think it's a very different experience. And yeah, so in Spain, I think we should feel very proud of the response from the population, and in terms of complying with the measures, in terms of willingness to get vaccinated. I think in general everyone has been very responsible, and I mean, you saw it from the data, from the survey, and and people um, for example, when we ask people if they have been vaccinated, when they say no, they can say why not. And the options are no, because I don't trust my government, no, because I don't think the vaccine is safe. There are different reasons. The percentage of people in Spain saying no is very, very small. It's like, I think on average is 91% of intention to get vaccinated. So it's like 9%. And of those 9%, the percentage of people that say that they don't want to get vaccinated because they don't trust their government is very small. When we compare to Germany, because we have data from Germany, I think I can look at the data right now. Actually, I think the data from Germany is only 60 something percent of the people that want to get vaccinated. Yeah. And then when we look at why not, and we look at the ones that they say that they don't trust their government, there's actually a fairly significant percentage of people that say that they don't trust the intentions of the government. So so I think Italy is more similar to Spain. Brazil, I think, is also more, it seems to be more similar to Spain in that sense, at least in the vaccination, or at least the ones that answer the survey seem to be. But Germany, for example, is not like that. I'm looking at the data right now, I can tell you, but it's basically has a low intention to get vaccinated in Germany. It has And there's a big difference between former Eastern Germany and Western Germany, where Eastern Germany is much more skeptical than Western Germany in terms of the trust in the government. And right now, in the last data that I have from the last week of August, 24% of the people in Germany say that they don't trust the motivations of their government with the vaccine. Wow. 24% is extremely high. And yes. Then in Spain, the same week, the same answer is 2%. Yeah. So it's like less than 10, like more than 10 times less. Yeah.
That's very interesting. Unfortunately, I think we reached the time limit. I really would like to thank you. I think what you have been doing is remarkable, the kind of work. I want to congratulate you again for the XPRIZE win.
Thank you.
It's great work. I think we posted in both in the banner of the YouTube and in our website many of the links you provided. Thank you again.
Thank you.
And I hope you can invite you sometime again in the future where you after all this is gone and we can take a final conversation about all this work. Thank you again.
Yeah, thank you very much for the invitation. And yeah, it was great seeing you, and hopefully one day we can see each other in person. Thank you.
That's true too. Yes, definitely. Thank you again.
Bye-bye. Have a good day.
This was the Perspectives in AI seminar of the IBM USP C4AI. Please also, we have many interesting talks in this YouTube channel from other researchers. Please feel free to browse them. This talk is going to be available later as a recording. Thank you again. Thank you to all.
Ciao.